Thank you for Chairman. I'd like to talk about the outcomes of the arthroscopic repair of large to massive tendon with allograft patch augmentation. It's a preliminary report, and I showed my technique of the muscle advancement as a treatment method for massive rotator cuff tear. The treatment of an irreparable massive cuff tear include the following many options. In meta-analysis, patch augmentation showed better outcomes in terms of tear rate and ASES clinical score than the repair-only groups. According to the paper, partial repair combined with graft augmentation had a retear rate about 0.33 times lower than the repair-only groups. The concept of partial repair was introduced by Dr. Burkhardt, and the point is to restore false couples. According to the articles, the clinical score improved, but retear rate is high as 48.9%. So we try to do complete repair, not a partial repair, but when you do the complete repair, the problem with that is tension overload. Burkhardt demonstrated gradual failure when physiologic cyclic loading was performed, even after successful repairing of the massive rotator cuff tear. This means that the retear will gradually occur until it reaches a length equal to the shortened length, caused by original degenerative change in any form, whether type 1 or type 2 retear pattern. Several papers have attempted to find the appropriate proper tension for rotator cuff repair, and the forces greater than 35 newtons have not been recommended. In 2019, this article also showed that the retear rate increases when the tension is greater than 35 newtons. If there are a lot of debate on proper tension, and it's ultimately best to repair the rotator cuff with no tension. According to the Pattaya procedure, we cannot get a hint of how to repair a torn tendon to its original position while maintaining the length. In case of the modified muscle advancement, many Asian doctors have published recently. According to Dr. Yokoya's paper, arthroscopic treatment with muscle advancement can achieve the significant better result and a lower failure rate. Additional papers show that the patient who underwent PGA patch for muscle advancement for reinforcement had a similar outcome to isolated muscle advancement group. Surgical technique was shown as below. They found that the patient with muscle advancement PGA patch group had a low failure rate as 12.8% than patient without patch augmentation. Here's my technique. Make an incision along the medial border of scapula, previously drawn marking near the scapular spine, and detach the supraspinatus and the infraspinatus using a corpse elevator. This is the scapular spine, and this is supraspinatus and infraspinatus. And then we use the corpse elevator to the lateral side. Afterward, further check the releasing the retracted tendon and the degree of the cuff reduction. And if the footprint coverage is not achieved 50%, perform reinforcement using allograft patch. First of all, fix the medial anchor, and after that we pass the cuff. Make the patch right size, then pass sutures through the patch that passed through the cuff before. Then use the double pulley technique to secure the medial low tightly. Using the suture bridge technique to repair the cuff and the patch covering the original footprint. This is I'd like I'd like to share my tips. I would first perform a complete intra-articular capsular release and the CH release in the subacromial space and the suprascapular release and the supraspinatus and the infraspinatus then detached from the original site and moved to the lateral side muscle sliding with no tension. So this video showed the intracapsular release. This one is the suprascapular release. So anyway, the follow this procedure, intra-articular capsular release fully, the superior and the posterior, all of them, and then went into the subacromial space, and I released the coracohumeral ligament, and then just to find the base of the coraco base, and then move to the medial side. At the time that we find the conoid ligament, after that, just to follow the below, we can find the transverse ligament of the scapula. So release the ligament, that means suprascapular release. After that, the outside of the skin, the scapular medial board, I check, make an incision. After that, I use the corpus elevator, light, and then release all of them. Be careful about the suprascapular nerve. So we have to touch the bone. Then is most important. So this is a subacromial space. I release the coracohumeral ligament, remove the bursectomy, and then after that, sometimes I do a medialization. So I remove the cartilage in the within 8 millimeter or within 1 centimeter. After that, step by step, I release all of them and then check the step by step, check the retracted tendon, check the reduction of the torn tendon. So outside of the scapula, so I already talked about the supraspinatus insertion, and then I contact the base bone. After that, I use the corpus elevator and then the release, go forward to the medial side. We have to check the length and then infraspinatus word like this. And then at that time, when we put arthroscope into the subacromial space, and finally we check the all release supraspinatus, infraspinatus, like this. So in subacromial space, we check all of them. After that, try to reduction to them. But some patient, we released all of them to the touchdown to the original site. At the time, in the repair only. But sometimes less than 50%. At the time, the partial repair. After that, patch augmentation. So this slide is the partial repair. Sometimes I complete the repair or footprint. After that, patch augmentation, reinforcement. This is the demographic of my study. There is no statistical difference between groups except age. About clinical scores, we can see the study group had better outcome than control groups. And in terms of the return rate, we found even more dramatic result with a 24.5% return rate in control group and no returns in study group, even though they were limited cases. Comparison between the patch and no patch group within the muscle advancement group did not show difference, no differences in clinical score and acromial-humeral interval. I shared some ideas. So you can see that as a treatment for massive irreparable rotator cuff tears that cannot be repaired, I think the only anatomic reduction that can be achieved is a complete repair using a patch augmentation with a muscle advancement technique. So we should perform complete release such as capsular release, coracomeral release, suprascapular nerve release, supraspinatus release, infraspinatus release, and it is important to reduction of the torn cuff with no tension using the muscle advancement techniques and complete repair using patch augmentation. There are some limitations. Conclusion, when we repair the torn tendon, we should do not under no tension, which can achieve through the complete release. Second, arthroscopic repair with muscle advancement technique had a very low return rate comparing the original techniques. But there are not significant differences between muscle advancement patch augmentation group and no patch groups. Thank you for your attention.